My client returns today after treating the right ilium for a downslip pattern. And she's much improved. So if you could just give us a quick summary of how it's improved, but also then tell us what remains.
The pubic symphysis is really a lot better. I don't feel any instability in that. I can walk more even, and when I sit I can still feel my butt bone, my right butt bone. I haven't felt that in a while.
So you feel like you're sitting more symmetrical?
Yeah, my right shoulder wasn't hurting anymore. I haven't had the need to hold my pants in a way that holds my legs together because they were hurting so bad. I haven't had that. And in a way that still hurts. I still have a little bit of leg pain, and I have a little bit of waddling when I'm walking.
Yeah.
A little pain back here still.
Yeah, and I could observe that. When you walked, I was a little disappointed today because it looks like there's still a little bit of a waddle, and so I'm wondering why. And so I came back and we retested the spring test, and I'll show you what we find. I will like to add that even though you had pubic symphysis symptoms, I didn't find any movement dysfunction there. It was treating the ilium that helped that.
Helped my hips too.
Yeah. So when we do a posterior rotation spring test, I can distinctly take up the slack on the left, and then I spring it, and it moves and it comes back. It's very different on the right side. On the right side, I can take up the slack, but I can tell it's a little uncomfortable. But then when I try and spring it, really, it's really not moving. Okay? Let's have you lie on your stomach. Now, you do have superior spring mobility.
Which I didn't have yesterday.
Yeah.
It's sore though, yeah.
Yeah, so you no longer have a traditional downslip, okay? And you spring this way as well. What I found, this is a pattern I discovered. I had this pattern from a motorcycle rack. And I had pubic joint instability, and when I corrected this pattern, my pubic joint stabilized.
Wow.
Yeah, I used to have to treat it all the time.
We're twinsies.
Yeah, sort of, except wrong side. Yeah, mine was on the left. Yep. So this is called an oblique downslip. Now with a traditional downslip, we're talking about hemipelvis shifting down slightly in relationship to the sacrum. We corrected that yesterday. And what you present with today is an oblique downslip, as though this hemipelvis slid off obliquely at a 45 degrees infralaterally. So it's like this hemipelvis shifted down that way. Okay? And what we find when that is present, on the other side you have good oblique mobility. I can push, take up the slack, then I can spring it. Okay, I'm capturing the PSIS, part of the ilium. So I can also do that inferiorly. Okay, when I come to this side, I can see that the PSIS is deep. Is it inferior? Really subtle, really too subtle to tell. But you'll notice I can't take up the slack obliquely. There's no movement that way. And when I come this way, there's no movement. I can't take up the slack that way either. The sacrotuberous ligament is softer than it was yesterday, so that doesn't give me information. But when I palpate the sacrospinous ligament, it does feel tighter on the right. I'm trying to spring it, and it's just really not yielding. On the left side, I can indent it and I can spring it. And you made a comment on that as well?
Yeah, it just hurts. It feels really tight, and it's painful when you're pushing.
Yeah. Yeah, very good. So it feels tight and uncomfortable.
Yeah.
Okay, so this oblique downslip is extremely rare. It's a very, very rare finding. It's not in the literature. It's in my advanced home study. And the treatment is pretty straightforward. We want to glide that hemipelvis back up towards the sacrum. We want to close that joint obliquely. And it might be that this happens in people who have a distinctly different shape of their SI joint on one side. And research has shown us that a lot of people have two different shapes of SI joints. And there is an accessory SI joint, an extra joint outside of the SI joint in some people, and maybe you have that. You know, no one knows. But the treatment is pretty straightforward. What I like to do is put 2 pillows under the stomach.
Okay.
And then that opens up your lumbar spine and it protects your lumbar facet joints, okay? So only under your stomach, not under the bony pelvis.
Oh. Like that?
Excellent, excellent, beautiful, okay? I'm gonna drop the table down.
This won't pose an issue to my left kneecap, right? Dislocating?
No,
Okay.
no, we're only treating the right side.
Okay.
Yeah, yeah. So the treatment technique for this oblique downslip is to take the hip and then I bring it outward just to a comfortable 45 degrees. You have more range, so I could go further, but 45 is plenty. Some people it'll be less than that. So then I stabilize the pelvis here because I don't want to torque your lumbar spine. I just want the ilium to move. And this is what we do. So your right hip is abducted 45 degrees, and I'm lifting the thigh up into extension. Okay? And if I could complete this arc, put your left arm to your side, please. So if I could complete this arc, I would touch your left elbow with the back of your foot. Does that make sense?
Mm-hmm.
So I'll step aside and just show that angle. Okay? The other thing that I like to do is after stretching this for about a minute, then what I add is I add a medial glide. Now I'm adding, you know, this is a rotation, but then I'm adding a glide or a shear. So I'm pushing into your thigh. And I like to hold that for about a minute. And I know it's a little boring to just watch a treatment, but it's only 2 minutes, so we'll just keep on filming. And then I bring it up a little bit further and just maintain a very steady, gentle force. And I'll hold that for about another 30 seconds. I feel a little bit of give, so I just follow that give. I lift the thigh up as it releases, as it allows me to lift it up. Okay, so I'm going to bring it down now. And I don't think you'll ever need to have this treated again, but I will teach your husband how to do it.
Thank you.
The self-treatment I'll show you when you're up, but for the benefit of people watching the video, the self-treatment would be to bend forward over a table and take that right hip and take it outward, take it outward about 45 degrees or whatever's comfortable. This is my comfortable end of range, and then you just rotate, bringing the heel towards my left elbow. My left elbow is at the side of my body. So it's extension with abduction. Okay? So let's take this out now. So once in a while, somebody with a traditional downslip of the ilium will come back the next day and it converts to an oblique downslip. And you're that example. Okay? Very unique, very unusual. Look how much I can take up the slack now. And now I can spring that obliquely. Okay?
Wow.
And now I'm going to go inferiorly in an oblique direction. And you can see I can easily take up that slack. And I can spring obliquely. And now let's look at that sacrospinous ligament. So here's the ILA of the sacrum. So I just come laterally. And my thumbs look of equal depth. And I can indent that ligament slightly. Is there less pain?
Yeah.
Okay. Could you walk down the hall and come back and tell us how you feel?
I think I'm gonna just need a second.
You're walking faster than you did this morning when you
Weird.
when we looked at you earlier.
Yeah, feels good.
Nice.
Yeah, feels normal.
Good. Go one more time. So elaborate. Tell us some more.
Feel like I'm walking the runway.
Uh-huh. What does that mean?
That I can walk when I couldn't before.
Okay.
Weird, I don't know. My leg can act normally.
Uh-huh.
Feel like let's go dancing.
You're smiling, so I know you feel better.
What the heck?
Wonderful. Wonderful.
How do you know all this?
I just was stubborn. I just kept studying the body and I trusted my hands. And when I would treat somebody with a traditional approach, but then I would still feel difference in ligamentous tension or in soft tissue tension, I trusted it. And then I just went home and looked at the pelvis and thought, what is every way a pubic joint can move? What is every single way it might move on one side? And then what's every single way it could move both of them together? What's every way an ischium would move? Of course, that's part of the hemipelvis. What's every way an ilium can move? And can I test that with passive motion testing? And that's how I stumbled on this.
But
So just
my
tenacity.
body speaks to you. My
It
body's
does.
what's told you what's wrong with me.
It does.
Fabulous.
It does, yeah. Yeah.
I really appreciate it.
Sure, sure. And so I'll have your husband test you every day for a week for the traditional downslip and also for this oblique downslip.
Okay.
Okay? And then I'll have him treat you for those if they're present.
Okay.
We already showed the treatment for the traditional downslip. Yesterday's video, whether it's in part 1 or part 2, I don't remember, but we showed how I treated the superior glide for the right downslip. Another way is to wear a yoga strap and you wrap it under your sit bone so it's inside the leg and you bend over and it goes around your shoulder and you tighten it up. So then that circle becomes smaller than the circumference of your body so that when you stand upright, it's pulling up on that pelvis. Okay? So that's another way of self-treating it.
Okay.
And then the other way, if you want to bring the camera over here, I'll demonstrate the other self-treatment technique that I like. And what you do is you lie on the floor in your doorway. And you have to scoot your pelvis almost through the doorway. Okay? So I'm very close to this door frame. My foot goes on the door frame, and then I point the knee outward. So it's pointing outside of my right shoulder. Okay? And I'm scooted down far enough that I feel an upward pull through my thigh. Okay?
Okay.
You don't do it if it hurts.
Okay.
Pay attention to your hip joint, you know, the inguinal crease. You don't want to cause pain there. But it's a very, very gentle
Way to push it up.
up and outward
Yeah.
pull.
Yeah.
And so you just position yourself there and you stay there 3 to 5 minutes.
Okay.
All right? And that's the self-treatment.
Wonderful.
Good.
Thank you.
Well, interesting presentation. And just to reiterate, you had surgery for a labral tear
3 years ago.
3 years ago and a chondral defect, tear of the cartilage.
And a ligament tear.
Yes.
And now that all that damage is back.
Yeah, you've had
And now,
both hips look.
Now both hips hurt.
Uh-huh.
Both SI joints hurt. The pubic symphysis felt unstable. I've recently been diagnosed with the hypermobility EDS, and I was pretty much at my wit's end of 10 years of chronic pain and not knowing what to do next other than maybe go through with surgery on all 5 joints of my pelvis because it feels like it's becoming completely destabilized, and in like a 5-minute thing here and a 2-minute thing here, I'm like stabilized and I don't have surgeries and rehabilitations and years more of crap, so I don't even know what to say other than thank you very much.
Yeah, and so your hips feel better now.
Yeah, I don't have the need to pull my pants together for my hips, no.
Uh-huh.
My pubic symphysis, that's gone.
Yeah, it's kind of a mystery. You know, how
And I can
does...
feel my right foot like on the ground when I'm sitting. I can feel my right butt bone. I can feel that my right leg's back. I
Yeah,
have
so
felt
when you're
stuck for
sitting,
so
you
long.
feel like your pelvis is symmetrical, whereas before it felt uneven.
Yeah, I feel like I have my legs back.
Yeah. Well, that's fabulous. And I tested your hips, and I didn't really produce hip pain, so it made me, some people have labral tears, and they live well with them.
Mm-hmm.
So
Yeah, my biggest complaints were my hip pain.
Uh-huh.
So I think this twist and stuckness of my pelvis stuck back into the right, and the only realization that I had of that being a problem was because when I would push the top of my hip bone forward, I would feel relief in my hip joints. I feel like, wow, there's oxygen, blood flow, like opening, that takes away my hip pain. And so that's why I kind of came in with you like, hey, I think I'm stuck somehow, and you found where I was stuck.
Yeah, and the other important lesson, let me just demonstrate some of your hypermobility through your hand. Okay, so here is lots of MP extension, metatarsophalangeal extension, and then certainly a lot of extension distally as well. And your elbows hyperextend, look at that, that's 15 degrees. And other joints as well, you have tremendous amount of hip flexion. You are a classical hypermobility syndrome person, and it's been validated that you have EDS. And the important thing that I want to say is that there's a mythology out there that a person has EDS, they injure their pelvis, they injure their SI joint, and they think because of that diagnosis that suddenly the SI is unstable.
That's what I felt like.
Yes.
Like
that's
I need
what
a
it feels
fusion. Like I need a fusion to stabilize my SI joints through my pelvis. That's what I felt.
Yeah, and that's what it feels like.
Mm-hmm.
Was anyone proposing fusion to you?
I'm just radio frequency away from getting it fused. Yeah.
Got it.
Not anymore, but
yeah. So they were taking you down that road.
Yeah.
And with you, your ilium was stuck in inferior glide, and it was stuck obliquely. Even though you have hypermobility syndrome, this was not an issue of hypermobility. It was a malposition, and correcting it, it feels very stable. I don't think it's going to come down. I think it would take another passive force. And so I want to address that mythology, that just because you have EDS doesn't mean your pelvis became unstable. Okay.
Or that you're bound to life in just chronic pain and deal with it. You can actually seek help for it, and not just through surgeons.
Right.
This biomechanic restoration and your kinetic chain, this is what I've been trying to say to physicians. Tons and tons of physicians, I'm stuck. Can't you feel this? Can't you feel what I'm talking about, where I'm hurting? They don't want to watch me walk. They don't want to feel where it hurts. It's just my imaging has damage, so let's do surgery. But this is what I needed. And I'm surprised at how simplified.
It is simple. It is simple. When you understand how the body functions, and every joint has that little bit of spring mobility, and that is so fundamental to the way that I evaluate the joint. The traditional model does not do that spring testing, but that's what taught me what to do with your body.
I wish every physician had to as a mandatory need to be able to practice medicine, had to take your course at least 2 weeks. So
the other issue is, a lot of people would have said, oh, you need prolotherapy because you have hypermobility syndrome, so you need injections. You need to stabilize the joint. That's not true. You needed to mobilize it in a correct functional relationship. So, Victor, any words from you? Any thoughts?
Super excited that she feels better. She's got all smiles. That's good for me. So, I'm definitely going to take his advice as far as what to do, how to evaluate, how to treat, make sure we make that into a positive pattern in our lives. We're going to reevaluate our course of action for her. Like she said, we've been involved in medical community in various specialties, areas of liabilities, kind of the microcosms of I can tell you about this, but not this. So this gives us a little bit of hope, a little bit of a breathing room, and we do appreciate your passion into it. So thank you.
Thank you, and I appreciate being able to video this because downslip is not understood well.
Mm-hmm. And I had the pregnancy fall 10 years ago. My left knee dislocated. I fell on my right hip. I fell in a way to protect my stomach with my arm cradled, and I wanted to fall on my butt because that was the furthest thing away from my stomach, from my son. That mother instinct was taken over. and that's where I fell. And so chances are
That was the cause.
that was probably the cause. So chances are, even if I didn't have him self-treat me or I didn't self-treat, I may stay with the upslip or without the downslip anyway, right? Because it
Yeah.
would take a lot of force for me to re-injure myself that way. So chances are, even if I did nothing, I'm probably going to go on feeling better now that
Correct.
you've unstuck me.
That's
Okay.
That is my absolute belief. That's my
Just wanted
absolute
to be
belief.
clear, yeah.
I believe this will be a one-time
Because
correction.
that's what my body says to me.
Sure,
Yeah.
sure.
My whole right side of my body has absolutely changed since yesterday.
And that's really interesting. That's
Yeah.
another phenomenon. Because after we treated the downslip, you sat up and you said, my whole right side, my face, my shoulder feels like it's releasing. Is that a good word?
Yeah, I felt really dizzy, like blurry. I couldn't really see that good out of my right eye. I just had a lot of problems just even getting off the table. But then even throughout the day, I felt my right side of my face kind of almost feeling like it's relaxing downwards, like as if something had been scrunched up, but it was like going downward. More openness in like my chest on my right side, and then my abdominal, like inside of my, like my guts, my intestines. I don't know. It felt like everything that was scrunched kind of was like had room to move over.
Yeah.
As weird as that sounds.
Yeah.
And then there was no pain anymore near that pubic symphysis bone or whatever off to the right of it. Just all of that gone.
Interesting.
Yeah.
I never would have predicted that. I have no model for that. I don't know why the shoulder girdle and the neck and the face feels
Just felt
freer.
like, yeah, I was always stuck this way, and my shoulder wanted to help be come back to normal,
Yeah.
you know, and it just to be able to walk this way when you're stuck this way, you're hurting everything because you can't walk at a diagonal. So you helped me walk straight again, and yeah, I really appreciate it. Thank you so much.
Oh, you bet.
Really appreciate
Absolutely. Thanks very much. Thank you.
you.